patients who are also the poor candidates for surgery, they are going to be offered non-operative management. So what we do in non-operative management is observation, because as we discussed as stepladder phenomenon, so patients may plateau deteriorate. NSAIDs are very much important because they reduce the inflammation, lifestyle modifications, and therapy. So whenever there is a 1 or 2 level disease, ideally it is recommended that we do and the patient is having the anterior compression, it is recommended that we do anterior cervical discectomy fusion or a corpectomy. And if ever the patient is having majorly a posterior compression, that is when we do a focal laminectomy only. Multi-level disease, more than 3 levels, with a significant axial neck pain. In that case, multi-level ACDS versus corpectomy versus laminectomy and fusion or anterior or posterior may be considered. If the patient is not having significant axial neck pain, in that case, you are going to see whether the kyphosis is present or not. If the kyphosis is present, you have to see whether there is a prior laminectomy or not. If there is a prior laminectomy, then go for anterior or posterior surgery. If the laminectomy is not there, in that case, multi-level anterior surgery or corpectomy or anterior plus posterior surgery. If the patient is not having kyphosis, the patient is having a mild to moderate flexible kyphosis, you're going to go ahead with a laminectomy and fusion. Neutral or lordotic spine and a young patient, I would say, in that case, you might consider doing laminoplasty. So depending on the compression, whether it is anterior, posterior, and the number of levels, you're going to decide whether you do an anterior surgery or a posterior surgery, or even a combination surgery in the cases where it is required.